Namaskaram. A very good morning from our lab at Visakhapatnam. Today we have a young female who has a brain hemorrhage. So this is the MRI of this young lady, which is showing there is a bleed on the left half of the brain. And because of the bleed, the patient is having weakness on the right half of the body. Then she was investigated with the MR angiogram and MR venogram of the brain, because it could be an arterial bleed or sometime a venous bleed because of a dural sinus thrombosis. Hemorrhagic infarct can also look like that. So in MKCG hospital, they have investigated the patient at Barampur with MR angio and MR veno. They have suspected the patient is having a brain AVM. That's how they have referred the patient to us. So we did a DSA angiogram and we found there is an arteriovenous malformation. Arteriovenous malformation is basically a complex lesion which is having an arterial component, a venous component, and then in between there is a nidus, which is a weak area. We did a 3D rotational angiogram as well, which is confirming there are a couple of the arterial freedom is a single, and there is a nidus, and there is a venous or the major venous drainage, and there is a minor venous drainage also, and there is an aneurysm which has bled. Although, please open the door. Although if you just look at an AVM which has bled, they are generally a little large in size. Here, it's typically it's a small AVM which has bled. Now, what is an indication for treating an AVM? Basically, having a brain AVM is not per se an indication for treatment. But if the AVM is troubling the patient, we plan for a treatment. So what kind of trouble a brain AVM can cause? The most dreaded complication of a brain AVM is brain hemorrhage, like in this patient. So once a brain AVM has bled, that is an indication for a treatment of an AVM, number one. Number two, if the AVM is giving rise to intractable headache, which is not responding to medication, that's an indication for treatment. Then the other indication for treatment is seizure or fits, which is not being controlled with multiple medication. That is an indication for treatment of an AVM. If they are not there, like brain hemorrhage, like a seizure uncontrolled, like a headache uncontrolled, we generally observe the brain AVM. We don't go aggressively with the treatment. So what are the treatment available today for a treatment of brain AVM? Number one is an embolization. Without cutting open the brain, a small pipe is put from the groin into the neck, and we go inside the nidus, which is the weak area on the AVM, and we embolize it. So that is an embolization. Second one is an open the brain, find out the AVM, and do a microsurgical excision of the AVM. And the third one is a radiosurgery. So just put radiation and try to get rid of this AVM. Now, what are the advantages or disadvantages? Basically, in surgery, if the AVM is deep-seated, it's very difficult to excise. And if it's superficial, small, surgery is good enough. As well as embolization is a great option for this treatment. And the radiation treatment, once you give radiation, or we call it a gamma knife, the AVM slowly reduces over a period of 1 to 1.5 years. So once there is an acute bleed of an AVM, we don't give gamma knife because this is going to take time for the AVM to get cured. So that is not an indication for gamma knife. So here we are going ahead with embolization of this AVM today. So with us, the cameraman, we have Srinu, the smart boy with us, who is recording live for us. We have Parvati, who is assisting me, and we have Prasad, and we have Gauri, who is a chief technologist and chief assistant. We have Dr. Ramesh, who is a neuroanesthetist, and her assistant, his assistant, Bharati, is with us. So let's go ahead. Sure. Right. दिखा रहे बेटा. So you can focus on the screen. Yeah. So we are trying to navigate into the left carotid, because the left ACA is where we have the supply of this AVM. can I have the screen closer to me? So this is the right carotid, and this could be the left carotid. And take an excess lateral, please. Heparin, give it. So another interesting discussion can be which are the AVM we must treat. Basically, as I told you, any AVM which has blades with an intracerebral hemorrhage is an indication. Angioarchitecture wise, looking at the AVM angiography, we can also decide that which are the AVM which might bleed. So what are the dangerous angioarchitecture of an AVM which is an indication for a bleed? This is pneumonia. So the first one is an AVM which has an aneurysm on its feeding artery is an indication for treatment. Number two, a nidus of the AVM which is having an aneurysm inside, which is called an intranidal aneurysm, is an indication for treatment. Number three, if there is multiple fistula, there are multiple fistula inside, this intranidal fistula is an indication for treatment because it tremendously increases the flow inside the vein. And the number four is basically a long tortuous vein which might increase the internal pressure, is an indication for treatment. And the other one is tight stenosis at the venous side is also an indication, because once the exit path, the vein is having a stenosis, obviously you are going to have tremendous pressure inside the nidus which might bleed. So the embolization again can be done by a transarterial method or a transvenous, which is actually transvenous plus transarterial. Although we say it is transvenous, it is a combined venous and arterial approach. Here we are doing a purely arterial approach to treat this AVM. So we can use the liquid embolics, which could be onyx, squid, tail bleach. Right. So we can see the IVM. Okay. Can you give me an IVM? So we will prefer a distal access catheter, a 5 French or a Navian going all the way distal so that we have a very stable position. So today we are choosing an AVM to go distal. I will love my catheter sitting at the supraclavian ICA so that my sonic is very stable when I'm doing the treatment. Okay, out. So we have the Navian simply just sitting there. We're not in a hurry to push it up because we are anyway going with a. Can I have the sonic with hybrid? So we will be using a detachable tip catheter. There are two detachable tip catheter available to us in India. One is Sonic and one is Apollo. So what does it mean by a detachable tip catheter? The catheter tip is detachable. So when we are embolizing, we are using a glue kind of spherical kind of material, let's say for example, and the tip of the catheter might get stuck with the kind of nidus, the kind of the cast we create with Sonic or Onyx. So when we pull the catheter, automatically it gets detached. So it's called a detachable tip catheter. They made the embolization very safe so that the chance of intracranial hemorrhage when we are detaching the catheter is very, very little. This is Sonic from Balt we are using today. Yeah, hybrid. So perfect. Arvind should have been there asking questions and continuing the discussion. Come on. So we will give a gentle shape to the wire. Okay, ma. So this is the detachable tip catheter. The catheter will have 3 markers here. So this is the distal tip of the catheter. This is the proximal detachable zone, the middle detachable zone, and the proximal. So your onyx or your sonic, the squid can come all the way till here. But this is no. The last end of the last marker, the most proximal marker, is the danger zone. You should not come with your liquid embolic till that point. So this is a young female. What is the age? 26, 28? 33 only. Can I have the screen closer to me and give me epicranial? Yeah, just push it forward. Oh, wonderful, wonderful, great. Epicranial. So we have been treating AVM since 2006, and quite a lot of AVMs that we have treated. MAGMAG. Reduce the cranial. Reduce cranial. Reduce. A little more. Enough. Right. It's quite a relaxing experience to work with a team of people. Roadmap on the last one. Yeah. So we will approach the anterior cerebral artery and try to get the AVM. Thank you. Doctor. थोड़ा सा लाइट कम करेगा हॉल का. So this is an important step to cannulate the AVM. Basically, we are going there. So as you see, the catheter is approaching the AVM. So now meanwhile I'll try to take my AVM a little bit up. So I'm trying to approach the AVM. We can see that slowly moving towards the nidus. Okay, ladder. So this is the AVM nidus we're approaching. We should be going with the appropriate view for that. So it's a absolute lateral is our choice here to look at this AVM. Table down. Table. Beautiful. So we have our guiding in view, most important, so that you know what is happening. Sometimes you have a slack, sometimes the whole system dropping into the heart. It's better to have your guiding within your view, so we can see that. Stop. So this is the AVM nidus. Roadmap for that. And we have reached. Our catheter is slowly getting there. Right. So we can do a microcatheter injection to understand what is happening there. Right out. Wonderful. So you can do a gentle microcatheter run. You're very close to the nidus. You don't have to really inject forcibly. Just simple run. Roadmap out. Table please. Max mag. Table. So it's very important for us to have a clear view of the situation. We are right at the nidus, so beautifully placed. Stop. So there is a small branch coming out here, which we may not be able to save. As we have said, there are two venous drainage, one the major and the minor venous drainage. They are going into the suprasogittal sinus. We are very close to the nidus here. The options is go with the glue or go with the squid. We will go with the squid here. Maybe we'll try to progress our microcatheter a little bit after there and start injecting our squid wire pitch. So very well placed in the nidus. So it's very important for us to understand the pathology before we actually go ahead and treat such lesions, because they are super complex. We do a lot of other intracranial disease treatment like aneurysms, the intracranial atherosclerosis, and the neurofistulas. I would say that to understand and treat an AVM in the brain is the most complex. So we have to have a very good plan before we start. So I will try to progress about 3-4 millimeter more, and we'll start injecting the liquid embolus. You can see this detachable tip. See, this is the tip of the catheter, the distal tip, and the proximal detachment zone and the distal detachment zone. I can come anywhere here, 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 but not beyond that. If you come beyond that, then you are stuck. So that's all. So this much is enough for us. Yeah. So I'm well in the nidus here. So thanks to these beautiful technologies which allow us to go inside the blood vessel in the brain or have a good visualization, so that our treatment is well targeted, and possible complications are very less. So I'm just touching to understand. Yeah, fine. So I'm super happy with this position, thank God. So here I will inject 10 cc of normal saline before I go with the DMSO and other things. 10 cc normal saline. We'll start with 18. So I will flush my microcatheter with a normal saline 10 cc. So how do you know that you have really treated a brain AVM? That's possible when you have really closed the vein. Once you have closed the vein of an AVM and you have no complication, that means you have actually treated the AVM. Because the vein is the exit path of the AVM. Once you have closed the vein, you are bound, obliged to take the complete nidus. So our treatment strategy will be to take the foot of the vein and the part of the vein, the nidus and part of the artery. Then we can really understand that we have completely treated the AVM. That will be our goal. Let's see how things are for us. So we can also inject glue in such a AVM, but more and more we are using the non-adhesive liquid embolics like the squid, the onyx. So unless there is a really high flow fistula, we are not interested to inject glue. So we will start with 18, and if we get a good reflux, then wait to form a plug, and then we can inject the 12. The pressure cooker technique can also be done for AVM. We have been doing it. So we do an alternative pressure cooker technique, not the conventional one that is been promoted by our professor, teacher, Rani Sapple. What we do is we take a second catheter, and once we get a good amount of reflux, then we inject 66% couple of drops of glue so that the plug is formed. So that is an alternate way to do the pressure cooker. The real pressure cooker is you take a catheter, the second catheter, and you inject some liquid coils and a drop of glue before you start your procedure. Okay. So can I have a roadmap reset? So I'll try to inject on a blank roadmap to understand the migration. So it's just going right into the vein. So we can go a little slow here so that things will so you can see a good amount of reflux. So we will hold here. So we can see one of the vein, the minor vein is gone. So we have a major vein filling and a part of the nidus is filling. Prasad, can you stop here? Stop. So you can see this vein is there. The second vein is gone, and there's a part of nidus which is still left. Yeah. So we wait for a while because of the reflux that we are getting on the catheter, and then that could be for about 30 to 40 seconds or a minute. Don't wait for so long. Reset. So you see the reflux and you wait, and it needs a little bit of patience and understanding. When you're embolizing an IV, we should not be in a hurry. We should not be really aggressive to push things. It's always good to wait, understand what's happening, and then so here we are getting a reflux. We can wait. A couple of minutes more, 1 minute more, 30 seconds more. We just wait till I found the plug. Now, to avoid that kind of waiting, we do basically pressure cooker technique, which we will try to show you the next time. With suppose we form a plug here, there is no chance of reflux. You just inject, it goes forward, it embolizes the AVM, and you can come back. Reset. So now it's going forward and also coming backward. So wait. So if the AVM is large, then we do a partially targeted embolization. So our idea will be to take the vein, come back the nidus and the artery, but you should not push your liquid embolics to the vein to begin with. So try to settle down in the nidus. If it is large, then try to avoid pushing your liquid embolics close to the vein. So go away from the vein, go to the least supplied. Suppose you have major multiple arterial feeder, go to the arterial feeder which is the least supplying. Like surgical principle, you just have to dissect from the periphery and come to the center. Like that, if you have multiple arterial feeder, you go to the least dominant feeder, start embolizing, because you will have the draining vein very close to the major feeder. So in that, you have a risk of occluding the vein and still left with the nidus. So here, because there's a single feeder, all those principles doesn't apply. So we just wait, try to see that the plug is formed, and then try to inject. Reset. Okay, epicranial. Perfect. Go back to lateral. Heparin given. Time. Reset. So we are still getting the reflux. Srinivas. So what are the challenges in neuroanesthesia in such patients, Ramesh? What special precautions you do, or what is other different things that you do for interventional neuro procedures, neurointerventional procedure? Anything different?
Close watch on flow diagram.
Okay.
Never allow BP
Mm-hmm.
and also never allow patient to move, especially when you are close to the target.
Okay.
Never allow patient. And
Reset.
Prepare because in case any bleed happens.
Okay.
Prepare to tackle the situation.
Right. In case of an intracranial hemorrhage, what you do? Reset process.
We will try to bring down the pressure. We will try to control the breathing.
Okay. Oh, we're getting the reflux only. So you can see basically the catheter, the detachment zones, the proximal distal. So we are trying to form a plug very close to the nidus so that we don't get a long reflux. So sometimes it is more waiting than doing anything. So that can be, very interesting, that you're waiting more, doing less, but doing less will be better if that is the need. So as I was saying, that when the AVM is large and disembodied, we plan for a targeted embolization or partially targeted embolization, where we treat the nidus, internally the aneurysms, the aneurysm on the supplying arteries, and then we stop and we allow the patient to come out of the initial bleed and then try to tackle the AVM. Reset. So some forward movement, but there's how the blood pressure.
106.
So here again we are close to a branch coming up there, so we don't want further reflux. Reset. How much time since we started? Apparent time 11:30. 45 minutes. Huh? Oh, that's okay. Reset. So we got a forward movement here. So we don't like the distal movement there, but it'll be fine for us as long as we just take this nidus off. We are having some nidal penetration, that's right. Reset. So that's into a smaller RL feeder, which we don't like it much. We want, can I get 12? Squeeze 12? We want to change the flow direction. We have formed a plug. Reset, yeah. Reset. Reset. We're still getting the reflux. It's quite a long time. Reflux नहीं होने से उसको नाइडस में जाके क्लोज. So far so good, because as long as you have a vein exiting those little bit of nidus left, you're still safe. You will not have an intracranial hemorrhage as a complication. So just a little more patience. And once we don't have any reflux further, then there could be further penetration. Reset. Roadmap. No, I'm not liking the reflux here. Reset. Reset. So that's into the venous side. Gone. Now the AVM is completely gone. Gone. Student. So the AVM was getting upper supply. You see, completely that is gone. So you don't see any vein, you don't see any nidus, you don't see any. Perfect. Wonderful. Reset. So sometimes you just inject a little bit even after just achieving the complete embolization, because generally it is considered that the AVM is a little bigger than what you see in angiogram. It's a typical nidus pattern, so we don't want them to be there. And it's just looking beautiful here. A superb penetration of the. Can you show closer here, Sinu? So you can see this beautiful penetration of this nidus. So it's completely gone. Reset. So we will not penetrate further because it's going away from the nidus. We will wait for another few seconds and just see whether we penetrate more, and then we stop because the AVM nidus is gone. The vein, artery, everything has been taken care of. Reset. Right. So we will stop here, and now we will remove this catheter. You can see that there is very minimal and lightly. So you see this, the catheter has been detached from the detachment zone. You see only two, and you don't see the distal marker. So it's beautiful. So complete DMAG. All lights on. Cover the head. Yeah, table please. Table. Cover the head. Yeah. Table. Collimation out. Table. Yeah. So you can see that nidus, the AVM is completely excluded from the circulation. Epicranial. Mag. Table. All right. Contrast. Beautiful. Eleocran. That's all enough.